So we presented 2 cases of very aggressive AQP4 positive NMOSD, where we saw chronic cognitive impairment that was going on for more than 6 months prior to the initiation of Eculizumab. And then they experienced significant improvement in cognition after starting on Eculizumab. So as many people know, Eculizumab is a C5 complement inhibitor that was shown in clinical trials to dramatically reduce the time to relapse. However, it wasn't shown to be of benefit for secondary outcome measures like EDSS, for example. We also know that cognitive impairment is relatively prevalent in NMOSD, so depending on the series, it's been reported to be prevalent in 30 to 70% of NMOSD patients. And cognitive impairment can occur in NMOSD even in the absence of brain lesions. So there have been pathologic studies that have shown that, again, even in the absence of brain lesions, there can be loss of cortical neurons and astrocytes, perhaps due to excitotoxicity and ongoing permeability of the blood-brain barrier. And pathologic studies also highlight the importance of complement activation and deposition, particularly at the time of relapses, but there is evidence now that even in between attacks, there may be, to a lesser extent, some complement deposition and activation. So in our 2 cases, we saw very prominent involvement of the corpus callosum and also an element of ongoing gadolinium enhancement on MRI. And the patients had significant impairment in independent activities of daily living that then improved within 2 months after initiation of Eculizumab, and that was reflected in cognitive scores as well. We also saw resolution of gadolinium enhancement on MRI. However, the patients didn't fully return to their cognitive baseline, and they were still unable to work. So I think, these were 2 quite aggressive refractory cases of NMOSD, and they do help to support the role of Eculizumab therapy and complement pathophysiology in NMOSD. They also raise the question of whether cognition could potentially be a treatable target in NMOSD and could warrant an escalation in therapy. I think that we need a dedicated study, probably an observational study looking at cognition across multiple centers before and after initiation of therapy. That could be Eculizumab or other therapies as well to help answer this question of whether cognition could be a treatable target in NMOSD.